Dr. Anil Jasinha, Secretary to the Minister of Health and Mass Media. Guest of Honor, Director General of Health Services, Dr. Ja-ela. Guest of Honor, Professor Anita Simmons, Consultant Respiratory Physician, Royal Brompton and Harefield NHS Trust, and Professor Emeritus, National Heart Lung Institute, Imperial College of London. Our orator for today, Professor David Dennings, Professor of Infectious Diseases in Global Health, Chief Executive, Global Action for Fungal Infections, and Professor of Infectious Diseases at University of Manchester. Professor Dissanayake, the Academic Chair and the Chair Professor of Medicine, University of Wyoming, and Consultant Pulmonologist, National Hospital Canley. Distinguished past presidents of the college, council members, presidents and members of the other professional colleges, deans of medical faculties and academia, ministry officials, members of the Uragan family, together with my family, distinguished invitees including the headmaster and school teachers of St. Thomas's College, Mannaruwela, senior management from the industry, ladies and gentlemen. Ayubowan. May you live long. That is the blessing that we invoke in a person whom we meet in the traditional Sri Lankan time. But with this person to live longer, he should have an appropriate quality of life, or else that life that is lengthened will not be of any use to him or the society. I cannot emphasize more on the importance of having a breath, a clean breath, where you can breathe in without any hindrance, any fear that it will damage your lung. And at the same time, everybody should possess a functionally normal lung where they can live without any hindrance. Even though, as pulmonologists, we consider the lung as the center of our universe, it is truly, in a sense, it is the center of the human being. And with this in mind, I basically, when we took over the council in 2024, we thought of having this slogan where we, as Sri Lankan pulmonologists, would stand for the right of each and every citizen of Sri Lanka for the right to breathe free, devoid of polluted air, devoid of chronic lung diseases that might affect them in the long run. And hence, in my presidential address, we would like to look at the past, be at the present and see how we can improve, and then we will forge towards a beautiful future, especially in pulmonology, where we can do immensely to uplift the patients or people's respiratory health in Sri Lanka. So, our Chief Guest, Health Secretary Sir, as well as our Director General Health Services, we have a very vibrant health system in Sri Lanka, which we all can be proud of. Our maternal mortality rates, infant mortality rates, the length of life of a woman and a man lives in Sri Lanka is almost in par with foreign countries which has a very high GDP than us. But when you look at the respiratory health, there is a lot to improve, and I'm really proud of you to have both of you here so that we will be able to have a beautiful plan within the next few years. Now, when we look at the future, it is always important to remember our major contributors that made us this college up to this level. So this is the original document that gave birth to the Sri Lanka College of Pulmonologists. And you can see the stalwarts, or that means the major consultants who have been founder members of our society. And still they are with us today, advising for how to improve and creating advocacy and managing our patients in an appropriate way. And from there onwards, each and every past president of the Sri Lanka College of Pulmonologists did a brilliant job each year, sometimes in spite of having tremendous challenges in delivering these treatments as well as management options for our patients. So we are, you can see the star lineup of past presidents that we have, some of them who are in the audience today, and I think we should pay homage to them for the college that we are today. I'm very passionate about asthma. One of the major reasons is that, as this August audience will agree, asthma is a highly prevalent disease in Sri Lanka. Unfortunately, even though it is at the moment is highly prevalent, majority of them who have been diagnosed of asthma, unfortunately, are not properly controlled of asthma in Sri Lanka. And at the same time, we have the 10th highest death rate in the world due to asthma, even though we have very good healthcare infrastructure in place. So there are a lot of deaths due to asthma as well. So one of the reasons being that you can see in the left right corner where majority of the patients with asthma have to spend money from their hand to get the most appropriate treatment and the inhalers that they have. So we are really fortunate to have our Director General of Health Services who helped us immensely in bringing the guideline-based management of asthma treatment into the primary care setting this year. So hopefully we will be able to give our patients the best possible management for asthma during the next year, and hopefully we will be able to reduce this burden of unnecessary expense to the patients, and we can improve the asthma outcomes in this country. And one of the important things is neglecting what we call mild asthma, and then the overuse of salbutamol inhaler causing increased mortality and morbidity. And in that aspect, we wanted to educate our doctors, general practitioners, as well as our medical colleagues, and we had a beautiful program lined up throughout the year where our colleagues involved in various talks on asthma and online talks on asthma to improve the knowledge base of our doctors throughout the country. Tuberculosis is considered a poor man's disease. Unfortunately, in the 1900s, we actually had, with a 2 million population in Sri Lanka, we had about 4,000 deaths of tuberculosis in 1900s. And we were able to bring it down gradually. And by 2000, we had 62 per 100,000 incidence, the prevalence of tuberculosis. So due to our activities and the healthcare system, we were able to control tuberculosis to a certain extent. But since then, we are stagnating due to tuberculosis. And sir, that is one reason that we are going down in the healthy disease, because we have poor tuberculosis outcomes. Each day, when we offer tuberculosis treatment free of charge for each and every person in Sri Lanka, each day at least 2 or 3 patients die because of tuberculosis. So we lose about 800 patients per year who are diagnosed of tuberculosis, who can be completely treated and cured. In the context of we having low HIV/TB prevalence, and at the same time, in the context of we having very low amount of multi-drug resistant tuberculosis in our country. So this is an important aspect that we have to look into in the future. For that, I think our Director General Health Services helped us immensely in bringing out the concept of long-stay wards for tuberculosis, because we saw that patients who are having tuberculosis with a low socioeconomic state were having malnutrition more than 75% of the time. They were having multiple comorbidities like uncontrolled diabetes, liver diseases, and renal functions. And these patients have multiple comorbidities, and majority of them, 50%, are above the age of 65 or 60. So these patients who are already severely ill needs proper assessment and treatment under a proper medical care. Then at least in the first 2 months, we will be able to provide them with appropriate nutritious meal, and then we will be able to look after them properly until they have at least the intensive phase is carried out forward. And one other important aspect that we have to highlight is the lack of critical care facilities to manage severe tuberculosis when they come. Even at this moment of time, in my ward in Kalutara, I have young patients who have come with severe pneumonia, lungs are completely destroyed, on inotropes, needing antibiotics. And we actually, at least in the major teaching hospitals or provincial general hospitals, if we have a critical care facility in which we can intubate, give high frequency oxygen for these patients, give intensive care for these patients, we will be able to save majority of the patients. Because none of the ICUs, because we know that in Sri Lanka we have a limited amount of ICU beds, and because of that, when a tuberculosis patient with acute tuberculosis goes to the ICU, they have concerns, obviously. Hence, they will not get the proper management. So if we have devoted infection control measures are taken, and if we have these ICUs or critical care facilities, I think we might be able to save most of these patients from death. Probably not all death. And at the same time, we took ourselves to educate our doctors about tuberculosis, having collaborations with HIV and sexual health disease colleagues, going out to Kandy and having a peripheral meeting under the patronage of Professor Dushanta Madagedra and our colleagues there. And we have been immensely working towards giving the knowledge and improving the attitude of tuberculosis in Sri Lanka. Not only me, the past presidents as well. COPD. There is a huge change in the management and the diagnosis of COPD in the world. And there are new guidelines that are coming, and the classifications are changing day by day. And unfortunately, we expect by 2030 to have a huge amount of COPD in the world, and it is not different in Sri Lanka as well. In the Sri Lankan context, according to the studies done by Dr. Kirti Gunasekara mainly and our colleagues, we have identified that the cohort of tuberculosis in Sri Lanka are probably not male-oriented, male-predominant smoking cohort as in countries such as United Kingdom or USA, but we have a significant proportion of people we have females having COPD together with bronchiectasis. One of the main reasons for that is that we are exposed to biomass fuel from the young age, and these are damaging the lungs of females who have never even taken a cigarette into their mouth. And these patients have very poor outcomes, and because they have a lot of comorbidities with them. And until recently, we actually didn't have the most ideal treatment for COPD, probably up to about 2 years. We were managing them with the same way that we were managing asthma and asthma as well, with steroids sometimes. But during the last 2 years, we were able to introduce tiotropium into the healthcare system. And this year, we were able to introduce metered dose inhaler for tiotropium under your patronage and guidance. So hopefully, within the next year, we will be able to improve our patients' outcome in COPD. And at the same time, we were improving the knowledge base of doctors, having collaborations throughout, and I'm happy our colleagues from the College of Physicians as well as the internal medicine colleagues are here, and we together we can do miracles in controlling COPD. Not only the chronic COPD, by bringing in drugs, and this year we were able to actually initiate the bringing of long-acting bronchodilators as well as long-acting muscarinic combinations as well as triple inhalers, probably not in the government sector but at least in the private sector. It will be hopefully available with the help of our industry within the next year, and we will be able to change completely the outcomes of COPD patients together with pulmonary rehabilitation. I'm proud to say that most of our colleagues have started pulmonary rehabilitation, which is a guideline proven mechanism where you can improve outcomes, especially in the Colombo Chest Clinic as well as in National Hospital Gaul, as well as various parts of our country. We have been able to initiate pulmonary rehabilitation clinics, and the outcomes have been improved as well. In the acute management of COPD also, we have been having a lot of workshops to improve the knowledge of these doctors on NIV, non-invasive ventilation, and hence we have been able to reduce a significant amount of morbidity as well as mortality in patients with COPD and other diseases. Bronchiectasis is unfortunately in Sri Lanka at most of the instances due to a sequelae of tuberculosis. So I think that